this next session we're going to have actually is particularly of interest to me because as a physician, like many people who are in the healthcare profession in the United States and elsewhere, it's become a profession for many that they wish to leave. You know, they start out with this immense idealism and passion and compassion to serve and care for those who are suffering, and then they find out that the entire system in and of itself is one that destroys their idealism, drains their energy, and results in them burning out. And we're going to talk about burnout a little bit later, but this next session is how do we advance compassion in healthcare. And Mandy and I were just talking, and actually I gave a talk a little earlier this morning to the board of directors over Dignity Health. And fundamentally at the core of healthcare is not only compassion, but it's contained by love. And really love is the glue that holds all of this together, this sense that there is great value and it is critically important that we embrace others. And not only because they are suffering, but really just because they're a fellow human being on this path. So we're going to begin, and I'm just going to keep talking to the last person sitting. So I may have to tell another joke about a torn pair of pants here, if you guys. So we're going to begin this session, and I was saying just before we began, one of the mnemonics that I use that keeps me centered as a doctor, and I was just telling Mandy this, is these 10 letters of the alphabet, which I actually go through with intent. And I gave this first to a group of students who are just about to start medical school at their white coat ceremony. And I think this sets the intention of what we're talking about at this moment. And that's this part of the alphabet, which is C for compassion for self and others, dignity, recognizing the dignity of every person, equanimity, forgiveness, having gratitude. The hardest one for a neurosurgeon is always humility. You guys don't have to respond so quickly. Integrity and having personal values. Justice, the concept of our responsibility to watch out for those who are most vulnerable in our society. Kindness, which is the active component of compassion. And then, of course, contained by love. So that's where we're going to start today in the context of the healthcare environment and our desire to alleviate suffering. So we will begin. Thank you.
So hello again to those of you who were here yesterday. I'm going to be talking today about the culture of love, and particularly in healthcare organizations. I'm going to do a deep dive into 2 case studies that I have been spending the past few years investigating. And it's a little bit different than the way we typically think about culture in business organizations. And in fact, it's quite different than business training in general. I first want to acknowledge my collaborators at the University of Pennsylvania, Dr. Sigal Barsaid and Dr. Nancy Rothbard, both at the Wharton School. You know, we use words like all and everyone to describe our relationships with each other, and they have become like family now. We've been so close over the years, and this work couldn't be done without them. I came to Stanford as a grad student to study culture, specifically to study organizational culture. I was very eager to go. They had some of the world's experts in the topic, and I thought, this is fantastic. And somewhere along the way, I wrote a small paper called Emotional Culture. And I wrote it because, strangely, this literature on culture, which was so pervasive, had been written about. There was a zeitgeist since the 1990s. It affected almost everything that we do in organizations. But curiously, had systematically left out emotions, all emotions. You know, in fact, some researchers, my own advisor included, had gone as far as to say that the definition of culture is as a set of cognitions shared by members of a social unit. And I said, Charles, well, we have to change that. I mean, you've actually defined it as such. And he said, yeah, I don't know, I'm not really an expert in emotions. You should call my former student, Sigal Barsaid. She's really interested in emotions. And indeed, she had spent the first part of her career studying discrete emotions. So we actually had kind of a merging of the minds there to study what we now call emotional culture. We have a definition of it. I don't expect that you'll ever remember it, but maybe just a little piece of it. We thought a long time about what to go in there as the visible norms and artifacts, as well as the underlying values and assumptions reflecting a degree of perceived appropriateness and actual expression or suppression of discrete emotions within a social unit. Now that's a big mouthful, and the reason that it's set with the backdrop of the iceberg is that when we go into organizations, what we typically see are the artifacts, and I'm going to talk about the importance of the artifacts later, but we typically see that surface level, and it's very, very difficult, even for insiders, to get really into the deepest levels of the cultural assumptions. But I would suggest it's all part of a system that we can help change as people who are engaged in this work in compassion, and all of you in the audience and the organizations that you're in. Today's focus is going to be specifically on the culture of companionate love, which is a little bit different than compassion, but think of it as sort of the umbrella under which compassion falls. And what I'm talking about specifically is a basic emotion, and we heard yesterday from Dr. Ekman on basic or universal emotions. This is often recognized as one of them, consisting of the discrete emotions of affection, caring, tenderness, and compassion. So this is not romantic love. This is not what you hopefully feel for your spouse. You probably feel this too. This is what you feel for, sometimes the metaphor is for family or family-like relationships. It's a distinctive emotion, but like other emotions, it has physiological sensations, subjective experience, cognitive appraisal, and behavioral action tendencies. It's known as fundamental to the human experience, and it's unique for our purposes because it's other-focused and it's shaped by the social context. This is particularly important for us studying it in organizations because we want to study emotions that are shared and that are contagious and that can actually define the culture of organizations. I had a very interesting discussion last night with Dan Batson about whether love is even emotion, what kind of emotion is it, and I said, well, if you actually go back to the emotion models of the 80s in terms of how emotions are structured in our minds, I know you can't read this, but if you go to the far left, you see love, and then actually those three branches are the three components of love, and the largest to the far left is what we're calling companionate love and what others have called companionate love, and then only next to it do you see romantic love, and then out by itself is longing, which I think is very interesting as well. So this is an emotion that has been written about extensively and is really fundamental to the human experience and indeed to cognitions. We decided about, 5, 6, 7 years ago to study it in healthcare organizations, which for anyone who's in that literature or in that world has been described as a world of emotions. And it's so important for our purposes because loving relationships are actually viewed as part of rather than separate from work interactions. So it's sort of like going in and finding an extreme case or an exemplar where love is so much a part of the fabric of the organization that it actually begs to be studied. It also has some of the most pervasive challenges. We'll talk a lot about that tomorrow, but including, for example, some of the highest levels of dissatisfaction, burnout, and turnover. So this is an industry with an incredible amount of problems that organizational researchers like to help solve, but also a context in which is a natural ecology for love to be studied. I'm going to present two studies, and hopefully I can get through without asking you to read too many words. The first was a study of a long-term care facility and hospital in a large metro city in the East. Our study is a little bit different than what we've been hearing so far because we, again, look at culture in the broadest sense. And to do so, we really needed to look at as many people as possible who were a part of the culture. So those include the employees, but also the clients. They're actually called residents because they live in the hospital, and the families of residents. We really wanted to test the hypothesis that culture matters so much, it actually ripples out not just to the clients, but to the clients' families. So an extremely strong test of our hypothesis that love matters. We measured culture in a lot of ways, which I'll describe in a second, and we also wanted to look at how it affects, broadly speaking, employees and patients and their families. So we looked at physiological measures, HR measures, satisfaction, attitudinal measures, psychosocial measures, nonverbal measures for the patients who are actually nonverbal, and we looked at it over time. So we weren't able to do, in this particular study, a quasi-experiment that I talked about yesterday, but we wanted to look at what is the effect of varying levels of culture of love on these outcomes in the future, in this case 16 months later. We measured culture as broadly as we could because, again, we wanted to make sure we were really getting at culture. And to do so, we needed to not only ask employees, but we actually were able to employ what I think is one of the gold standards of this kind of research, insiders, outsiders. These are people who knew the units well and could actually go in and not only recognize love when they saw it, but recognize the difference among units. Sometimes in culture, we have this problem of the fish in water effect, which is you're a fish in water. You really can't tell about the culture because you've never lived outside of that fishbowl. So we really wanted to make sure we got inside and outside. These people averaged about 8 times a visit to each unit, in which case they filled out incidents of a culture of love being expressed on the unit. We also asked employees to rate it, and we asked the family members of the residents, about 80% of whom were nonverbal. So it was very important to actually ask, the ultimate recipients. These are people who have put their loved ones in the care of these care providers. And lastly, and some of the most interesting set of measures for me was a measure of cultural artifacts, which I talked about a little yesterday. And these were measures of homeliness and warmth reflected in the actual physical environment. In terms of dependent measures, we measured employees in terms of engagement, teamwork, satisfaction, and also withdrawal, including emotional exhaustion and absenteeism, which is sort of the first symptom of other problems that come, usually turnover. In terms of patient outcomes, we measured their satisfaction and quality of life, the verbal population, and then we measured mood in the nonverbal population using a geriatric measure as rated by their primary caretaker. And we did have some objective health measures. We also measured family satisfaction. This will not be interesting to most of you, but this kind of data does require special methodology, in particular multi-level modeling. So we did so using hierarchical linear modeling. I'm happy to chat offline with anyone who's interested about that. To summarize what we found here before moving into the second study, one of the most important things we found, which particularly for business audiences is important, is some evidence that actually interpersonal relationships in the workplace can be strong enough to be called love. Strong enough to be called loving relationships. To some people, they view the workplace as a place that's bureaucratic. It can't engender these kind of relationships. We found very strong evidence that it could. We also found that emotional culture can reliably be measured both by insiders, insider-outsiders, as well as the farthest recipients of this culture, which is the patient's families. We found that a strong culture of love positively impacts employees, patients, and their families in terms of all those measures I showed you, except, interestingly, health measures. I think future research really needs to get more into, in particular, some of the physiological measures to understand some of the pathways linking culture and health more directly. Another interesting finding is we found that this type of culture had a particularly strong effect on some kind of employees, in particular, employees who are naturally positive themselves. In these employees, what we found is they got an extra boost from being in a strong culture of love, which suggests some implications for HR, which I'll talk about later. Okay, so we didn't want to stop there because in some ways, like going to an organization like this that welcomed us, that said we want to be more of a culture of love, was kind of easy. Instead, my other co-author Nancy Rothbard and I wanted to look at a more difficult context. So we went into a context in which there are a lot of emotions, but it's also one of the strongest masculine cultures that we could find. And specifically, what we're looking at here are firefighters, many of whom some of you may know are actually primarily doing medical calls now. So responding to, every time you call 911, these are the folks on the other line. So these are the people before they actually ever make it to the hospital. We started with a qualitative study because we really wanted to get in depth about what do these emotional episodes look like in an organization where it's not encouraged to talk about emotion, it's not encouraged to ask for help, so how do we create cultures around that potentially? We then followed it up with a quantitative study where we tested some of our observations out using survey measures as well as objective performance measures. So what did we find? In the interviews, we found that the emotional culture of fire stations was defined in terms of 2 primary emotions. The first is the word joviality, which actually has been discussed in the emotion literature for about 30 years. and it refers to playfulness, so a feeling of free activation and play. Sometimes it manifested itself in amusement, and anyone who knows firefighters, you should know they're extraordinarily funny. The pranks, I don't have time to get into them today, but they're some of the most creative I've ever seen in my life. We also found a strong culture of companionate love, which, by the way, was a little bit surprising because, again, keep in mind, I was going into the most macho, masculine population I could find, so to see love pop up was quite surprising, except if you actually listen. So they would describe, for example, their relationships in terms of family-like relationships. They valued being emotionally close to one another, which they viewed as helpful for performance. So the same kind of values, assumptions, and norms we talk about, except manifested in this prototypically masculine way. So they didn't necessarily use the word love. In fact, no one did. But it was the exact same, exactly what we're talking about, including tenderness embedded in the leadership function. So one of the supervisors said, I have to take their hand and show them the way. And his subordinate said, yes, he's like a daddy to us. I mean, it was just incredible how they would use very powerful metaphors to describe what we call companionate love. We also noticed some pervasive problems around emotion suppression. So there was a very strong belief that the way to handle the trauma, the despair, the horror that they witnessed was to just put a lid on it and close it off entirely. It was not to engage in it. It was definitely not to talk about it. We call that in the literature emotion suppression. Interestingly, something we didn't expect as well was how much the strength of the emotion regulation impacted their family life. So we saw family life absolutely being affected by their inability to deal with emotions real time on the job. They described it as a callousness that got so severe they had an inability to connect with others outside of the organization. So the people closest to them, they actually had an inability to connect with them. And we noticed some pervasive challenges in terms of health problems, risk-taking outside the job, and also job performance. These findings are very challenging for us because in some ways they go head against the literature. So on the one hand, they believe that suppression is kind of useful for getting through trauma, yet the literature strongly shows that it's actually the opposite. It affects our memory, our cognition, our relationships. It also conflicts a lot of our assumptions around masculine organizations not being emotional or that work-family conflict is a women's issue. Very strong conflicting findings with that. So we went in and did a quantitative study because we wanted to study, well, what are these emerging relationships that we saw in the organization and how does it affect their behavior when we measure it using more traditional behavior and objective sources? What we found is that joviality and love actually are a boost to one another. So when you have a culture defined by both, in some ways you have the best of both worlds. You have the playfulness that they believed helps with coordination, and indeed we find some evidence of that. You also have the love that allowed them to express their fears, their pain to one another in a safe environment so that it didn't go home and bleed over. Now, it particularly mattered for people who were experiencing a lot of suppression. In fact, that's their preferred style, and people who were experiencing work-family conflict. So it wasn't just the case that it mattered for everybody, it did matter some, but it particularly mattered for the people who were the most vulnerable, who were the most pain. They were keeping the pain inside, it was straining their relationships with their family. For those people, the organizational culture had the biggest effect. And by the way, not joviality alone, although that's what the firefighters often said was the most important thing, it was the companionate love. So if you had joviality without companionate love, you did not see the effects. If you had them both, great. But if you had to have anything, the companionate love seemed to be the stronger of the two. So this highlights the tremendous importance of these variables. In terms of implications, what we're thinking about here is the importance of top management, to return full circle, to recognize the importance of emotional culture and actively managing it, just like culture, just like mission and values, the same things we're talking about, except in terms of emotions. And for leaders to actually model the behavior, actually to use these emotions and know that leaders disproportionately impact the emotional culture. And lastly, to hire the right people and for everyone, to create it through these small acts of compassion. I mean, the examples in the qualitative data suggested it was the small acts that really built up the culture. So thank you very much for your attention today.
Good morning, I'm Bridget Duffy. In listening to you talk, I remembered about 8 years ago when I started on a journey to do this work within academic institutions, sitting in a room with the academic chairs saying we need to focus on optimizing employee well-being and bringing empathy back to healthcare. And I'll never remember one of the chairs, he looked at me and he said, "Dr. Duffy, we don't use those words here. We are a data-driven, results-oriented organization." And I looked at him and I said, "I know you don't use those words yet. That's why I'm here." But I sit here dumbfounded and just applaud the courage of Dr. Doty and his team to have the courage to have this conversation. I never in my lifetime as a doc thought I'd be sitting here talking about love and well-being in healthcare. This is truly remarkable. You've really started a movement, so thank you so much. My life as a doc was altered about 20 years ago because of one patient. And it was only because I was tired, having been on call all night, that I sat down at the foot of his bed in the ICU, and I watched as every specialist came in and grabbed the chart out of my hand and went into the room and dealt with the machine that dealt with the defective body part, no one talking to, touching, or listening to the patient. And it was then that the light bulb went on that my patient wasn't diseased and fragmented, but the system was. And I came home that night in my sleep-deprived state, and on the top of my mail was a photo of a man in an article about a paper he'd written 50 years ago called How to Build the Most Healing Hospital in America. He'd gone to retire to Hawaii. I dialed 411. He answered the phone. I said, "I just read this paper. I'm a baby doc. I want to come help you build it." And he laughed and he said, "I've come here to hang out in a hammock and retire." That lasted about 2 weeks. And we've been on a journey for 20 years now to try to humanize the way we deliver healthcare. At the time, it's a good thing I didn't know he invented the pacemaker, founded a little company called Medtronic. Otherwise, I would have been too afraid to call him. But he's a remarkable man trying to lead this work. So it's led me to some roles in healthcare as one of the nation's first chief experience officers in healthcare. And shame on us that we had to create that role and that the government had to actually mandate that we measure the patient's experience of their care. But nonetheless, we're finally getting there. And on one of my experiences in an institution, I spent the first 30 days in this role just walking in my scrubs in the shoes of the frontline staff, the doctors, the nurses, the patients. And I came back into the boardroom and I said, I cannot focus on the patient experience until we first focus on the staff, the demoralized, the burnt out, the exhausted staff. And I said, and secondly, when I witness the first thing we do to patients when they walk into our lives in a clinic or in the hospital is we literally strip them of their dignity. And we put them in these pathetic gowns that you know, that with the back open or a paper one in a clinic that sticks to you. So one of the institutions I had the opportunity to fly to New York with a very enlightened nurse and sit down in the office of Diane von Furstenberg. Do some of the ladies know who that is? She's very famous for a wraparound dress. And we sat there and waited for her for about 20 minutes, and she came walking in and she says, "Dr. Duffy, why are you here? Every hospital in New York has asked me to redesign the patient gown. I have no interest in this." And I said, "Well, why not?" And she said, "I hate hospitals." And I said, "Why do you hate hospitals?" She said, "They smell, they stink, they're painful, people are rude." And I said, "That's why I need your help." I said, "This is what we do." And I opened up the gown and I said, "We strip people of dignity." I said, "I'm asking you to help me restore dignity and respect back to healthcare." And she looked at me and she said, "Now this I have some interest in." So she actually did that. And she created a prototype, designed it, and we launched the gown. And so usually when I share the story of who I am and my mission here on Earth, and when I don't have much time like today, I just use one slide that describes the journey that I have been on. Because it's not been very easy, and I often feel like this trying to change medicine. But in all seriousness, I'd like to just share really quickly a little bit of the path and maybe some of the mistakes I've made on the way and some things you could do to help support you on your journey. And it takes people in this room today to be supporters and be part of a community and mentors. And I have two mentors that pushed me, actually three. One, Earl Bakken, the founder of Medtronic. Two, the most important, my father, who I was born at Letterman Hospital here at the Presidio, where he was training residents. And he taught me three things. He said to me while treating all levels of the military, the Army, he said, "Bridget, you shouldn't have to be someone or know someone to get a great humane experience. You have to treat every human being this way." Second, this photo at their 50th wedding anniversary triggered a memory I had forgotten. He used to get up from the dinner table every night and call back every patient he had done surgery on that day. So it wasn't until I was at a large institution as a chief experience officer that I remembered this, because one patient in my patient advisory group said, Dr. Duffy, I come here for my high-tech procedures, but in between my appointments, I go across the street to your competition. I said, Jerry, why do you do that? We have the best outcomes. He said, because over there, they treat me like a human being. They understand how my disease impacted my life. They asked me what my greatest fears and concerns were. You never did once. So I said to him, if I asked you that today, Jerry, what would you tell me? And he said, well, after my second open heart surgery, I had a seizure and you took my driver's license away for 6 months. He said, I own the largest car dealership in town. My fear was you would take my license away for life, and it's my legacy, my independence. And he said, you never once asked that question. Overnight, we changed the system on the electronic record and the outpatient. First question asked, what is your greatest fear or concern today that you would like your care team to address? Not do you have insurance, do you have a living will, and here's your copay. One patient. So a couple weeks go by, my phone rings in my office. My secretary says, it's Jerry, you should take the call. And I said, Jerry, what can I do? You need help getting an appointment? And he says, no, I'm just calling to check on you in the car. How's it working out? I bought a car from him. And I said, oh no, please tell me after your 2 open heart surgeries, somebody from here called you to check on you to ask how you were doing? And he said, no. He said, you know, if you'd like me to join your advisory board, I could probably help you improve the patient experience. And I said, I would appreciate that. So Jerry and I were on a 2.5-year journey to try to humanize care at that institution, and he was amazing. The third thing my father taught me is he dragged me to conferences where there was a 90-year-old guy on stage named Dr. Deming when I was in high school, who talked about how to create highly reliable organizations. So this will come back to play in a second here. The last person, a mentor who pushed me to go faster is from Boston now, running cardiothoracic surgery. He said, Bridget, why don't you convene a group of doctors and nurses and CEOs from around the nation to define the standards of an ideal healing experience, not a hospital stay, versus us just reacting to what the government says is an ideal hospital stay. He said, I have an annual report card and I'm measured on core metrics. I'm not measured on things that matter to my patient. And he said, I'm gonna send you something in the mail, and most distressing, this patient was on my service. So I hang up the phone, open it up, it's question number 47 of 75 questions on the patient satisfaction survey, mailed to the patient 6 weeks after their stay, which is crazy. And question says, describe your overall experience here. She says, terrible survey. You did not ask one question about the psychological harm you cause with your procedures. If you'd only gone on to Google or Amazon, you'd find 20 books on depression and heart disease. Even though you saved my life and my heart is pumping, is that a great outcome? What are you guys, just mechanics? And here's the actual document he sent me, and he underlined in red the are you just mechanics. It was an absolute jolt to him. Because of him, we've launched, and I've now found about 50 physicians that have the title of Chief Experience Officer in the nation. I've helped 2/3 write their job description. And my team and I convene the group, almost 50 now, in combination with nurses and CEOs, in a CXO roundtable that we just hosted last week here in San Francisco, where our mission and our charter is to define for the nation the standards of an optimal healing experience, and to do that in partnership with Dr. Doty and Dr. Arnie Milstein at Stanford. And our goal is to meet not just the triple aim. The triple aim in healthcare that everybody talks about is finding care innovations delivered at the highest quality, the lowest cost, and in a patient-centered way. Our mission is to address the quadruple aim, which is about restoring joy back to the practice of medicine. So docs my age and nurses my age don't want to quit and go do something else. So we wrote our charter 3 years ago to come up with a checklist of always events to do that. But what I will tell you, what I witness when I'm out in the trenches that everyone is focused on are things that don't actually matter. They're focused on investing in bricks and mortar, and a great experience does not create a great human experience. A great building does not create a great human experience. At this institution, we spent millions on a new heart center. The week it opened, I get an email from a gastroenterologist, and she said, Dr. Duffy, I haven't met you yet, but I brought my 80-year-old father in for his 1-year open heart follow-up. We're now in the new building. We came walking through this beautiful hallway, art features, water works, and she said he stopped dead in his tracks and looked up at the check-in area and said, oh no, it's her again. And he was so riddled with anxiety. It took one person to destroy a great technical outcome. So I called up the heart surgeon, who had been a huge thorn in my side trying to get this work done. He viewed me as soft or fluff, or he called me the happiness doctor. And I told him what happened. And I said, look, it took one person to destroy your great technical outcome. He became an absolute champion for this work to try to humanize the experience. The second thing happening everywhere in healthcare is a focus on Lean and Six Sigma and stripping out waste. That's important. You know I'm a Deming devotee, but it's not enough. So what happens is it breeds a level of exhaustion if all you do is talk about stripping out waste with your doctors and your nurses. And a couple other things contributing to the fatigue in healthcare today is the electronic medical record, which we need, but we need ways to use it better. This physician was mortified when his 7-year-old patient sent him this grand drawing, that he sent this into the journal JAMA in the Peace of Mind, and he said, at what cost technology? She's on the exam table, her mother and sister in the chairs next to her. He's across the room with his back to them typing. He said, at what cost technology and what it's doing to the human relationship? So from the physician and the nurse experience, nurses spend 2.5 hours of a 12-hour shift at the bedside. The rest of the time they're typing and they're hunters and gatherers. Now from the patient perspective, this 93-year-old patient says to me, Dr. Duffy, databases, have you heard of them? Why do you all ask me the same question at the same desk at the same day at different institutions in your hospital? And because I have aging parents, I'm witnessing this firsthand. My 85-year-old wonderful Swedish in-laws in Minnesota my father-in-law needed a procedure. He had a mass in his brain. We didn't know what it was. So my husband and I flew back in. My husband ran the health system. I trained in this hospital. And I spent 2 hours in advance of the appointment filling out all these forms online. They told us to show up at 5:30 in the morning for the appointment. I told them we don't have to. Nothing will happen until 6:30. But because they're Swedish, we showed up at 5:15 that morning for this procedure. Nothing happened until 6:30. We walk up to the desk. They hand her these forms on the clipboard. And my mother-in-law turns to me and says, Bridget, why haven't you fixed this yet? So I need you, all of you, to help me fix this. This is crazy that we have these antiquated processes. And she then, a couple weeks later, my mother-in-law sent me this cartoon out of the Minneapolis paper. We have some forms here for you to fill out. More forms? Don't you have all of my information by now? Of course we do. This is just to help you pass the time. So many things broken that can be changed. And this is what we encountered at the check-in desk at 5:30 in the morning. She looked at, and I don't blame her. I blame who we hire, how we train them, and how we onboard them in the culture. She looked at me and all the family members and my father-in-law, and she said, first words out of her mouth, there's way too many of you in here. You need to get out of the waiting room, and only 2 of you can stay. First words out of her mouth at 5:30 in the morning. Couldn't help myself. Later in the day, in the morning, after he's tucked in and wheeled off to the OR, I walked back up to her and I said, I just wanted to tell you why there were so many of us. I said, we flew in from California because we were so afraid he might not get off the table alive today. And I said, you must be exhausted getting up so early. I'm on my way to Caribou for a Starbucks. Could I bring you back one? First time she cracked a smile that anyone cared about her. But this was a horrible experience for us. She could have looked up and said, you must be scared to death. What can I do to help you? But the second question out of her mouth that she said to us was, to my father-in-law, where's your living will? He looked at me and he said, do I need that today? We have given her that checklist of things to ask. You know we've done that to her, so we need to look at the systems and processes of what we're doing to our people. So anyhow, to cut to the chase, the key to the ideal experience in healthcare, restoring compassion and dignity, is you have to do these things about lean. I've got black belt Six Sigma gurus on my team. You have to take out the 7 types of waste, but what most people aren't doing is mapping the gaps in humanity. Find the 7 things you can put back in and hardwire. That's what creates an ideal hospital healing experience, not a hospital stay. And that's what's about humanity in healthcare. So here's our charter, and our goal is to create a checklist of always events, not never events. And we look for process and technologies that do these things, that they address the patient's emotional and spiritual needs, that we put doctors and nurses back at the bedside. We improve physician and nurse relationship and communication. We engage patients and families as equal partners in their care, and that we create a consistent, seamless journey that allows people to truly heal. So in closing, I'd like to give you a few of the always events that this network has come up with, where we map the gaps from the first impression before people arrive to the last impression after they leave. And when you look at complaint data, at one institution we had 12,000 complaints per year. The #1 bucket was in communication. Wasn't listened to, wasn't treated with dignity or respect, never knew who my doctor was. Don't you specialists talk to each other? Why do you always ask when you come into my room what the other guy said? Don't you know? So that is why my passion in healthcare with my team at Vocera is to try to map and understand the gaps in communication and deploy process and technology solutions that restore humanity. So a couple of them in closing. From the first impression, We were re-engineering the orthopedic experience, hearing all the horrible things from patients that went wrong. And this patient said, Dr. Duffy, there was one positive thing that happened. And I said, what was that? And he said, well, I was wheeled away from my family into the operating room. I was half naked, cold, freezing, and I was listening to all this chatter. And he said, all of a sudden the door burst open and the surgeon came in and he stopped all the commotion, made the entire team come stand around my gurney. Each person looked me in the eye, told me their name, the purpose of their job, and that they were there to help me get through the procedure. He said, I fell asleep and knew I would be fine, and I have sailed through this procedure. I said, oh my goodness. I said, what was the name of that surgeon and an orthopod at that? I mean, I truly couldn't believe it. So I gave me the name, I called up the guy and I said, Vic, I've not met you, you've never heard of me, but I said, this is the most incredible story, tell me about it. He said, Bridget, I've been doing this for 10 years. And he said, I have the best outcomes. He said, I've never lost an employee on my team. If you come to my holiday party and ask my housekeepers in the hospital what the purpose of their job is, they would tell you they prevent infections in my operating room. So very simple thing overnight to do. I've shared this story at Mayo Clinic and other places. It's become the new standard in orthopedic care. This is one of my favorites, and I deployed it with my father-in-law. Why is it right before we put somebody to sleep to do a surgery, we do informed consent? We tell them you can get an infection, bleed, even die. Please sign here. One patient said to me, Dr. Duffy, why couldn't you give me informed hope? So we've launched this. Heart surgeon Mark Katz at Bon Secours has made this a standing order on every one of his patients to ask them what their hopes are, their dreams are, their desires for the other side of that procedure. Another hospital in southern Missouri, Kennett, Missouri, launched something called a sacred moment on admission. 73% of patients have spiritual needs linked to stress, anxiety, and things that they want to heal, but we very rarely address those in healthcare. This hospital was the lowest scoring hospital in a large for-profit system in the Midwest. This surgeon was unrelenting in calling me saying, Bridget, help me. So we launched a sacred moment on admission. His scores went from the 30th percentile in the tank to the 90th percentile in 6 months. Sacred moment on admission was reconnecting doctors and nurses back to the purpose, and it was the intake process. And I'll share, I'm out of time, I'll share the details of what are the components of a sacred moment, and happy for you to be able to use those. Code Lavender, the last two here. Code Lavender, Earl Bakken, founder of Medtronic. This hospital opens about 15 years ago, and they launched something called a Patient Lavender. At his hospital, Patient Lavender goes out on everybody's beeper, Code Lavender to room 309. Everybody in the hospital stops and sends healing intention or prayer to room 309. Earl Bakken says to me 10 years ago, Bridget, do you think you'll ever be able to launch this at places like Stanford, Dignity Health, Mayo Clinic? And I said, no way, Earl. They already think I'm crazy enough talking about healing and well-being. But I saw him at his 90th birthday in January, and I said, Earl, I am happy to tell you, as far as I know, over 10,000 Code Lavenders have been launched at places like that today. You all know what a Code Blue is, rapid response team for the heart, the lung, and the brains. A Code Lavender, because of one nurse now, is deployed everywhere. She said, could we launch a Code Lavender for doctors and nurses? They just had to take 2 kids off life support in the PICU, and they're a mess. They've got to turn around and admit 2 new kids. So we called a Code Lavender to the floor, and it's a rapid response team to resuscitate the emotional, spiritual, and physical needs of patients, their families, and doctors and nurses in the front lines. And I always say, create a healing services team. And you already have these people. It's, you know, palliative care, hospice, alternative medicine. But call it healing services, because if you tell doctors you're going to bring in integrative or holistic medicine, they start to glaze over and have seizure-like activity themselves. So the only way to get work done in healthcare is covert with integrity. So very easy to launch a Code Lavender at your institution. The last couple, who knows what this is? One of my team members sent this to me. So you have teenagers. This is a Domino's pizza tracker. I did not know what this was, but I'm going to share with you 2 things that are still so broken that I would love for you in this room to come up with, and this would be worthy of a Nobel Prize. You can order a pizza and get an alert on your phone or your email that tells you, number 1, it's been placed, 2, it's being tossed, 3, it's in the oven, and a little factometer that tells you why it's delayed. But what I don't understand is how we can take a piece of breast tissue or prostate tissue or brain out of a human being on a Tuesday, and they have living hell through the week, not knowing whether they have cancer or not. Every single person remembers the date, the time, what they were wearing, and who they were with when they get the phone call that tells them they have cancer. This has happened 3 times to me in the last 3 years. This is my brother Tom in his 40s. A year ago, I'm here in San Francisco. He's on the knees in his living room receiving the news of a rare aggressive tumor of his finger. by himself in the living room. Yet we can track a Domino's pizza. Why don't we, before we take the tissue, ask them, how would you like to receive difficult news that my colleague is going to share in a minute? Who would you like by your side? How can we reach you? Or even giving you updates or alerts as to where it is in the pathology department, so you don't live in limbo, not knowing. Simple fixes to a broken system that we can do. And in closing, around last impression, because of one enlightened nurse, she said, why do we hand patients 50 sheets of paperwork and 10 new drugs at the bedside and shoot them out the door? What if we could audio record or videotape the discharge instructions? They could transmit it to their loved one as a navigator, get home and re-listen to it. And Arnie Milstein said to me, he said, Bridget, I wonder if they listen to the voice of their nurse at home. It's about building relationship and trust. And could that improve outcomes? Well, sure enough, at this institution, they targeted high-risk patients, and they reduced inappropriate readmissions to the emergency room by 15% and markedly improved their patient satisfaction scores. Very simple technology that we helped to create to try to improve the human experience. And a low-tech one that you can do, this is a nurse at Vocera, one of my colleagues, whose husband was dying way too young of bladder cancer at the University of Minnesota. And while she was sitting by his bedside, the nurse walked in, and Irene looked at the nurse and said, what am I going to do when I can no longer put my hand in his hand? Where will I get my strength? The next day, she came in, and after her husband had passed, the nurse had taken an imprint of his hand. She sent this to me. She says, every day today, going to work, I get out of bed, this sits on my dresser. It's how I get my strength to go on. So there's simple high-tech and there's low-tech things that we can do to restore humanity to healthcare. And that was a random act of kindness. No one at that institution knew that that nurse had done that. So thank you so much for being part of the dialogue.
Now that's love.
Yes, yeah. What an act to follow. Okay, I want to first thank Dr. Doty and the Center for Compassion and Altruism Research at Education and also Dignity Health for bringing us all together today. So I want to ask, how many of you are in healthcare? Oh, wow, great. How many of you are coming tomorrow? Say one, okay. And how many of you are clinicians, educators, researchers? Excellent. And then, how many of you are patients or have been patients? That includes your flu shot, right? And how many of you are human beings? Okay, we're good, we're good. So, oh, the clicker. So just to give you a little roadmap, what I'm going to talk about, there's a lot of challenges. I think Bridget outlined it beautifully, to relationships in healthcare. I believe that relationships are the medium of healthcare. I'm going to give you some concepts today about relational competency. We'll find out a little bit more about that. Partnership and relationship-centered care, everyday ethics, and reflection. And we'll talk a little bit about values and the development of the International Charter for Human Values in Healthcare. So I always start with this. Two of these are my children. Let you do guess. The practice of medicine is an art. This also applies to healthcare, any healthcare profession. The practice of medicine is an art, not a trade. A calling, not a business. A calling in which your heart will be exercised equally. So there are a lot of threats to healthcare today. I think Bridget outlined some of them. You know, the economic environment, it's focused on efficiency, productivity. There's rushed 10-minute appointments. I'm a pediatrician, and by the time the medical assistant weighs and measures and changes the diaper of the child, we have 6 minutes for the appointment. Continuity of care has become an issue. Lots about a communication. There's an erosion of values, and by that I mean there's less attention to values. Safety issues, there's increasing medical error, and also the primary care shortage. So the rush today in relationships, we don't have these deeper relationships, or they are being jeopardized. Communication, there's not time really to get to know your patients very much. The capacity for compassion is infected greatly. Tremendous burnout, compassion fatigue. And residents, these are residents in training, In medicine, in the 1980s, they spent 20% of their time with patients. Now they spend, in 2012, 12% of their time with patients, and half of their time is spent in front of a computer screen. That's more time than spent with you as a patient. So, here's what it looks like. Tell me, doctor, how much time do I have left? 10. 10? 10 what? 9. I love that. So, the Institute of Medicine in 1999 said, the first principle of quality healthcare is the development of long-term healing relationships long-term, with patients within a system of patient-centered care. So it's really all about relationships. That's the bottom line. I could tell you all the research. There's a tremendous amount of studies on this. If you're curious, just ask me afterwards. So relational competency, we sort of identified this as the ability to form deeper relationships with patients and families that goes beyond developing a set of communication behavior or skills. It's not a checklist. So the question becomes, how do we enhance relational competency? You know, we can teach our students and our learners, you sit down, you turn off your beeper, you look them in the eye, you say, that must be hard. But that's very different. Those get checked off on the checklists. That's very different than being present. You know, how do we enhance? How do we teach being present? How do we teach the ability to develop a sustainable relationship that allows for repair when mistakes are made? So the goal is sort of a way of being, a presence, rather than just the tasks and skills. Now you have to have the tasks and skills. It's good for your orthopedic surgeon to know how to do your knee. However, the relationship is essential. So I'm going to ask you, this is an analogy. Can you hear me? I'm sorry. Your patient is the bear, right? So this is pretend. Think out of the box. Your patient is your patient is the bear. Why is the bear in the tree? What is the bear's perspective? So, say it again? He's afraid. The bear's afraid. What else? He wants to see. Mm-hmm. He's what he said? He's saving a tree. It's an environmental bear. Yes, very good. Other ideas? He feels alienated. Mm-hmm. One more? Strangers are approaching. Excellent. He wants to feel safe. Right. So let's find out why this bear is in the tree. You see that little thing down there? This is a true story. Okay, that little thing down there is Jack the cat. This is a story, my sister sent me this newspaper story. Jack the cat was in Connecticut and treed this bear 3 times. And then I think probably Jack's parents, I'm a pediatrician, wanted to like maybe keep him inside so the bear didn't like change his mind and eat him or something. But basically the lesson here is we need to know the patient's perspective. We need to get to know each patient individually, I mean as much as we can within reason. So it's very important to understand the patient's perspective. The way we do that is we ask, what do they care about? What are their values? What's their culture? That sort of thing. So I want to ask you also, how many of you are familiar with patient-centered care? Excellent. So that's where we look at the patient's values and culture, perhaps religion, what is meaningful to them. So we really focus on the patient and try to individualize our treatment somewhat. But how many of you are familiar with relationship-centered care? Okay, just a handful, and that's what I'm finding everywhere. So the focus of relationship-centered care is how the clinician and the patient relate to each other. This is a two-way relationship. Relationships are the medium of care. We consider them therapeutic, and the studies all show that. So both patients and clinicians are active participants, and partnership and respect for the patient's participation in decision-making is valued. So what does the clinician bring? Being present for self and others goes beyond the patient-centered process. You want to become aware of your ideas and feelings and values in that relationship. And then what are the interactions within the clinician? Those are equally as important. Like I used to have a patient that had Munchausen by proxy that was harming her children, and the nurses would come up to me and say, oh, guess who's on your schedule at 10 this morning? Which wasn't very nice anyway in terms of the culture. But then I needed to say, what is it that bothers me about this patient? I can't fix it, but I need to be aware of that. And then I can go in and help the patient with more compassion, with more presence, with more awareness. So that's just a taste of relationship-centered care, and it involves paying attention to one's own behavior. So another concept are the ethics of everyday practice. So we all live in the same moral universe. There are universal human standards, maybe being fair, respecting others, discussing the right thing to do in every given situation. And this also applies to interprofessional practice. I'm doing a lot of interprofessional work. So the everyday ethics and habits of humanism and relationships have to do not just with how we treat patients, but how we treat each other, our colleagues, our healthcare team members. The third concept I want to talk a little bit about, and I realize I'm giving you a whole hour lecture in just a few minutes, but the time for reflection enhances practice. You think of the rush of healthcare today. There's no time for reflection. There's no time to really sit and think about what you're doing. But yet we learn by reflection. We learn by taking that experience and applying it to the next experience. It's cumulative. So Parker Palmer says the most practical thing we can achieve in any kind of work is insight into what is happening inside of us as we do it. So we know that reflection enhances self-awareness, and those enhance the moral aspects of practice. So we want to help physicians and other healthcare practitioners to contemplate their actions, to hold themselves responsible for their influence on patients, family members, and colleagues. 1 or 2 sentences. They're not going to, if a patient is dying and work with dying children, they're not going to remember what the morphine drip was or respirator settings, none of that. The family is going to remember the words that you say, and it can be very harming, it can be healing and helpful in the long run. So we also need to choose to act altruistically by supporting the patient's and family's perspective, and to reflect on the underlying ethical meaning of our work. Ron Epstein at Rochester has some wonderful articles on mindfulness and various things, and he talks about the ability to reflect will enable us as clinicians to develop insight into our interactions with patients, colleagues, and others, to listen to patients' distress, to be present during that suffering, to recognize their errors, to make evidence-based decisions, and to clarify their values so they can act with compassion, competence, presence, and insight. So we need all of that. So medicine is really a moral enterprise. This is written by Edwin Pellegrino, and I wish I'd discovered him sooner. He died in 2013 at age 93. Medicine is a moral enterprise, and if you take away the ethical and moral dimensions, you end up with a technique. The reason it's a profession is that it's dedicated to something other than its own self-interest. So we're trying to move beyond the technician and the factory approach and not lose that professionalism. And this was a narrative in the New England Journal of Medicine some years ago. A resident writing about Dr. Brody said, in medical school we're taught to follow a script, but then the script ends. Just like that, I was in over my head. I had no script, only clinical judgment. That perplexing skill that can't be reviewed in morning rounds or diagrammed on PowerPoint slides. So this is really, we can't have a checklist, even for communication. I was part of some of the communication skills frameworks, and we really have to bring our authentic selves to this. So how many felt like this? So we really can't rely on the script. We have to rely on our values, ourselves, our motivation to help and heal, our moral capacities. So then I want to ask you, all of you who are clinicians of any sort, practitioners, physicians, how many of you were explicitly taught values Now we assume that everybody should have integrity and honesty and compassion, but how many of you, was it in your curriculum during training at some point? Did you discuss it, explore it, write about values? How many? Not many. Yeah, that's par for the country. But values are the framework. They're the foundation of our work. So I'm going to just tell you briefly about the International Charter for Human Values in Healthcare. We started it in early 2011. It came out of a roundtable in Hong Kong that was sort of put together by several of us just serendipitously. And we decided we wanted to develop a charter because where were these core values in healthcare? So we're trying to restore the primacy of core values necessary for practicing compassionate, safe, relationship-centered care around the world. I want to acknowledge the most wonderful team that we started with. And we asked hundreds of patients around the world about values in healthcare. Just a quick thing, Human Values Charter is an initiative of IRCH, so that's really the International Research Center for Communication in Healthcare, co-sponsored by Hong Kong Polytech and University of Technology Sydney and Curtin, Australia. Curtin University in Australia is a strategic partner. So we asked hundreds and hundreds of people around the world, healthcare professionals who were also patients, caregivers, these two questions: drawing on your professional experiences and your experiences as a patient, what are the core human values that should be in every healthcare interaction? Then we asked them, they make their list, then we said, what are the top 4 from your list that you think should be present in every healthcare interaction? So I'm not going to tell you all about the research because at the poster session, poster 31, we have some articles that we can hand out for you of all the whole methodology. But we used a 3-year process, very rigorous, to identify and develop a framework of values. This is from data from all over the world. We used qualitative research methods. You can see the different types there. And what we came up with was 5 categories of values. Within each category are sub-values. Compassion has the most. So compassion, respect for persons, commitment to integrity and ethical practice, commitment to excellence, and justice in healthcare. So these are, and the fascinating thing to me is that these hold all over the world. Whether you're in China or Hong Kong, the Netherlands, Australia, the US, they come up with the same large categories, I think because we're all human beings. The other thing is, they might prioritize them a little differently. They might say one is a little more important than others, but they're all in there. So this is just an example of compassion. There's sub-values for each of those 5 main categories. And you can see here, caring, empathy, awareness, motivation to help, kindness, flexibility and adaptability in relationships, curiosity, that's coming up high in some of the courses I teach, altruism, mindfulness. So there's values for each of the other categories as well, but compassion has the most. The others have about 6. We just couldn't let them go. And so this is a word cloud of all the values in the charter, the International Charter for Human Values in Healthcare. And so you can see where some of those come up. The International Charter teaches about research, education, and practice. It's used to inform the work of the International Research Center for Communication in Healthcare and those initiatives. Also, what we're doing now, I'm almost done, is what we're doing is really how are we translating the international charters into education, research, and practice? So we have a lot of different initiatives going. The bottom line of our model is that the charter identifies these core values that we've determined qualitatively. There are many others. It doesn't mean those are the right ones, but those are the ones that came up in our studies. That relationships and skilled communication allow us to demonstrate those values. It's very important to make them visible. You might feel compassion, but if you're not demonstrating it in some way or aware of it, then the patient might just feel you're cold or quiet or whatever. So it has a lot to do with communication. So we're developing different educational and clinical programs to enhance these. The Charter for Compassion. How many of you are familiar with the Charter for Compassion? There you go. I thought I shouldn't even ask that, really. So basically, we also are partnering with them. That the International Research Center for Communication in Healthcare is the Asia Pacific Healthcare Hub. There are different hubs for the charter. You'll probably hear more about that in the week. And so it is serving as the Asian Pacific hub for the healthcare sector of the Charter for Compassion. So the healthcare sector, Worldwide Alliance, working together to promote compassionate, holistic, and relationship and cost-effective care. Join us. There's a website there as well. And also, I always like to say the Japanese proverb, none of us is as smart as all of us. So all of us working together in these wonderful, inspiring studies and work that people are doing, we can do it. So none of us is as smart as all of us working together. So the International Charter website, you can find that there. Our wonderful student assistants in Hong Kong have put it together. It's still under some construction or being updated. These two references are the main references for what I've just presented today. There are hundreds of other articles, but at the poster session, we can give you some of the copies and or find out how to send them to you if you can't get them. So I just want to say thank you. Thank you for the inspiring work. There you go.
Okay, so thanks so much to CCARE for putting this conference on and for inviting me all the way from UK. It's been a delight, an honor, and a privilege, really, to hear all these wonderful speakers and what's going on here. There's just so much, isn't it? Anyhow, so you've been sitting here for a while, so I thought what I would do is to show you a video. And I'm going to show you a video because I was asked to do something on the applications. So I'm actually going to show you some therapeutic techniques. And I'm going to think about, firstly, how did self-compassion therapies start? How did compassion-focused therapy start? It starts because we know that shame and self-criticism are linked to a wide variety of health problems. And our studies of shame and self-criticism revealed that there were different forms and different functions of self-criticism. So self-criticism is a very complicated difficulty. We did some early studies showing that self-criticism is a mediator with depression and other kinds of disorders. So if you have things like anxiety or eating disorders or depression or psychosis, self-criticism runs right the way through all of these. Self-criticism also undermines a lot of self-help programs. If you want to start a self-help program for dieting or for exercising, the things that will throw you off course actually is self-criticism. So we did a study looking at how does early parental life influence depression, and what we know is that it creates forms of self-criticism. As I've said, there are different types of self-criticism. One is the focus on inadequate, another is a focus on hating yourself. The inadequate self-critics are people who criticize themselves, often quite harshly because they believe they could do better, whereas the self-haters really don't. They just hate themselves, and they can be very self-harming as well. But we can also be self-reassuring. And we know that these are all related to everything. Everything relates to everything, except for the fact that when you do the mediation study, what you find is that the depression is all linked through those pathways. In other words, even if you have a bad personal experiences, if you're not too self-critical to yourself, then you're going to come out of it not too bad. Doesn't mean you could do well, but not too bad. So the real pathogenic factor in mental health is self-criticism. And I'm going to show you a video to show you how powerful this is and the fact that self-criticism is a whole body response. Okay, David, if you could show the video, that would be great. So this is a program we made back in the 90s.
A little bit more about the kinds of thoughts, kinds of situations that bring out in you this feeling of being a failure and just can't cope with it.
Even just something simple like being in town, maybe clothes shopping, and seeing other women, you know, and the continuous comparison thing, you know. She's tall, I'm not. She's slim, I'm not. She's tanned, I'm not. Things like that.
Okay, so we'll call that your social comparison voice.
Okay.
What I'm going to ask you to do is to enact that voice. So what I'm going to do is get out of my chair. Ooh. Okay, and I'm going to ask you if you would come and sit into this chair.
Okay.
Sit. Now that chair
See, I was a lot
is
younger
now
then.
Helen who becomes depressed. And this chair is you telling Helen those things you just told me. You know, you're not as tall as her, you're not attractive as her. Okay, can you tell her?
Okay, that girl over there in the corner of the changing rooms trying on those slinky trousers is at least 3 or 4 inches taller than you and slimmer than you. So you are, you know, kind of average in comparison.
The 2-chair technique is a technique which allows you to kind of isolate the negative voice in your head. So you can actually put it in the chair and let it speak to you and see what it says and explore its emotions and so forth.
You know, she just looks so much better than you, and
Notice the head
everyone
movements.
will think that.
Notice how
if
she's
you were to
looking.
stand side by side, everyone would think she would look better than you.
And then you can go back into the other chair and experience what it's like to be talked at.
Notice the
in
change
this
in
very
posture.
critical way.
Listen to what she says.
When you say things like that, it totally crushes me and reduces my worth to nothing physically, and I just want to curl up and die.
So that's quite significant.
You've got this constant
Look at this change.
picture in your mind of how you really would like to look and how you
Totally different posture.
would like to,
The
the
attacking
clothes you'd like
self
to
is
wear
sitting on the
and
hands,
everything.
kicking
But
the feet.
you don't do it. Or you try, but you fail. I know.
Watch the face.
I know. I just can't do it. Or can't maintain it.
I'm going to come and sit in this chair.
So it's another two more minutes.
Now, what would you have gained from that?
Very little, I would imagine.
So what does that, well, I'm not sure. What does that tell you?
That I'm far better qualified to drag myself down than I am anything else.
Absolutely
Far
right.
more experienced in it.
Absolutely right.
Mm.
Absolutely right. That's exactly the point. That your critical skills are brilliant. They are faultless. Your helping skills, your compassionate side.
So the point that I wanted to show you, because the video goes on and she does very well and so on and so on, but we don't have time for that. But what I wanted to show you is that you can actually move people around in chair work and actually get them into completely different physiological position states where they can have dialogues with each other. And of course, the thing that we will also be doing is training people in developing compassionate self. But the issue is that we have a lot of fears, blocks and resistances. When you're working with people like this, when you start to do compassion work, you run into a lot of fears, blocks and resistances. Now, we've done some work with depressed people, and this is the kind of things that depressed people say when you start suggesting them to develop compassion. I'm my own worst critic, so I sit there and understand things in other people, but I wouldn't necessarily accept them in myself. When I'm depressed, I just really, really don't like myself, so there's no way I'm going to feel compassion for myself. I know people that are very kind to themselves and they're good to themselves and look after themselves, and I think that's much better for it. But I don't think I'm really ever going to be able to do that. When I feel depressed, it's almost impossible to be forgiving towards myself, because when I feel depressed, I think it's my fault, right? So when you're working with compassion with people who have these kinds of mental health problems, you have enormous resistances. We also know that compassion is flow. Not only do we have resistances to compassion for themselves, but they also have resistances to accepting compassion from others and sometimes on being compassionate. And we did a series of studies where we developed questionnaires which looked at this, and Dan Martin touched on this yesterday. But we had 3 types of measures: the fear of compassion for others. People will take advantage of you if you're too compassionate. If I'm too compassionate, others will become dependent on me. Fears of compassion from others. I feel that if I need other people to be kind, they won't be. I worry that people are only kind and compassionate to me if they want something. So many of my patients will say to me, Dr. Gilbert, you're only kind to me because you're paid to be. If you really knew what went on in my head, you wouldn't be. If I think somebody's being kind, I put up a barrier. And then the sphere of compassion is for self. I feel that if I develop compassion for myself, I will become somebody I don't want to be. This idea that somehow compassion is about weakness, and this is why I think people like Philip Zimbardo's work is so important, because really at the heart of compassion is courage. I feel that if I'm more self-compassionate, I'll become a weak person. I feel that if I start to feel compassion for myself, I will be overcome with loss and grief. So here is some data. What we find is that compassion for others and compassion from others are linked with self-compassion. Okay, so you see they're quite highly correlated. Particularly notice the compassion from others and the self-compassion. In terms of anxiety and depression, we can see that the fears of self-compassion are highly linked to anxiety and depression, particularly in clinical groups. The clinical groups are the red groups. And just to remind you of the wonderful work that Dan Martin, Joachim Heinenberg and others are doing here, using the dyads, which Dan talked about yesterday, to remind you of their data, which is based on 84 business students. You can see that compassion from others and compassion from self, the fear of compassion from others and compassion from self, very highly correlated with depression. So the point is, if we're going to be working with compassion, then we have to understand the basis of these fears. Now, one basis of these fears of compassion is to do with emotional memory. Now, emotional memory is that which is located in different kinds of memory systems. So, for example, most of us enjoy sexual arousal. But if something horrible had happened to you, your own sexual arousal could produce trauma memory. Now, what we know is that for many of the people who have these kind of difficulties, these resistances to compassion, they actually are coming from traumatic or neglectful backgrounds. And so what happens is you begin to provide them kindness and support, you stimulate the attachment system, but what's in the attachment system is trauma memory, and so that's what comes back at them. John Bowlby talked about this many years ago, and talked about the fact that sometimes when you're working with clients and you're being kind to them, they'll actually get aggressive with you. Sometimes we work, because I work on a locked ward, it's a ward for people who have very severe mental health problems, who've been in and out of prison, many of them. And sometimes the nurses work with them and they are very compassionate and so forth, and within 2 hours, those patients are cutting, they're acting out, they're smashing windows with their heads, because what has been stimulated is the attachment experiences of remembering that previously when I had a close relationship, actually I got abused, I got hurt. Oops, gone the wrong way, sorry. The other reason that you get FBRs is that you have unprocessed emotion. Okay, not only do people misunderstand compassion, particularly if you come at it from the point of view of kindness and love, our patients will just freak out at that. You have to come at it from the point of courage, really. And the key thing is helping them understand that if they have unprocessed rage, that is a block to compassion, because they don't want to be compassionate. They need to find a way to deal with the rage of what was done to them. Or sometimes they have unprocessed fear. Many people that we work with who have anger disorders are absolutely terrified underneath. Again, if you come on some of our training, we'll show you some videos on that. And another major, major issue that blocks compassion is the inability to feel sad or to grieve. When we do compassion work, when we start developing the sense of a compassion itself, the thing that often first emerges, or emerges as after the anger and anxiety, is overwhelming sadness. Okay, so one of the first ladies that I worked with, who was a multiple suicide attempt, she was absolutely convinced she needed to kill herself. She cried for 3 months. Okay, and I remember talking about this in a psychotherapy group some years ago, and a very famous cognitive therapist came to me and said, "Oh, you don't want to do that." He said, "And you don't want too much sadness in your therapy. You've got to change the thoughts." So anyway, so the point is that I love cognitive therapy, it's great. So the key point then, when you're doing compassion therapy, is compassion sets a process running in the body where the body would start to try to heal. When it starts to try to heal, it starts to try and deal with its trauma memories. Those things will come up. And the unacknowledged pain of disconnection, the unacknowledged grieving, the sadness, the trauma, the tragedy of never really feeling loved, of never really feeling connected. And yet, from an archetypal point of view, that's what your whole being is yearned to be. That's what it needs. That's what it seeks. It's wanting to find connection. It's wanting to feel valued. It's wanting to be welcomed into the world. And if you've had that blocked up, when you start to open that up, the amount of sadness that comes up can be enormous. So one of the things that's important then is really helping to have a very clear definition of compassion, which was the definition that we used that I gave yesterday, which is sensitivity to suffering in self and others, first psychology, with a deep commitment to address that, both to alleviate and to prevent. And that requires courage of our patients. If you have an agoraphobic, right, that agoraphobic is going to have to develop the courage to go out and face their anxiety. If you have a woman who's in a domestically violent relationship, she may have to find the courage to leave. If you have somebody with OCD who are washing their hands 10 times a day till they bleed, they're going to have to find the courage to be able to tolerate the unpleasantness of not washing. So the key thing then is really de-shaming people about what it is they're feeling and helping them understand that compassion is the way that we build courage. If you hear tomorrow, and this touches on what's being talked about here, particularly in Dr. Duffy's talk, if you hear tomorrow that you've had a blood test that suggests that you've got cancer, the thing that you'll want to encourage you is a compassionate relationship. That is what will give you the courage. If you're deciding you don't want to go to the hospital because you're frightened to know what's going to happen to you, your friend will encourage you and will take you. So compassion is the way in which we are able to confront the most painful things in our lives when often we really don't want to. It is compassion that gives us that courage. So these are the kinds of things that we do in the therapy. We do a lot of understanding about the nature of compassion, the basis of compassion, the way in which compassion is designed to address suffering. We treat people with, we teach people the breathing and the posturals, many of the things that Steve Porges was talking about yesterday. We teach them how to use facial expressions. We teach them voice tones. Voice tones are very important. Self-critics talk to themselves in very harsh ways. Okay, I don't know whether you noticed on the video, but the lady there was talking in a very contemptuous way. So, and in fact, if you think about it, anything that you say, is how you experience is dependent upon voice tone. I mean, I could say to you, you know, everybody wants to be happy, right? But I could say it contemptuously, everybody wants to be happy? Or I could say it in a kind way, everybody just wants to be happy. Or I could say it in a sexy way, everybody wants to be happy. You know what I mean? Everybody happy. So the emotional tone. So we do a lot of work on teaching voicing for internal process of thinking, and we train people to do that. We teach about safe place and the difference between safeness and safety. We teach about joyfulness and playfulness, and we give people opportunities to experience those things. We teach people how to create the concept of an ideal compassionate other, and what's key to much of what we do is the concept of a compassionate self. And we use a lot of method acting techniques here, where we use postures and we use ways of thinking. If you were at your most compassionate self, how would you deal with this? If you were at your most compassionate self, how might you have dealt with that argument? If you were at your most compassionate self, how might you deal with this anxiety attack you've just had, right? And by practicing, imagining, stepping into the compassionate self, and we teach them a whole lot of things about wisdom and so on, they learn how to shift perspectives, take the breath, focus on the posture, create the voice tone, and by producing this combination of changes in body, posture, voice tone, they are able then to engage with what it is that's causing them difficulty. So the conclusion is, and I'm just on time, shame and some forms of self-criticisms are major targets for therapeutic outcomes. If you wanted to find a treatment that would help in self-help programs, that would help people maintain self-help programs, be it giving up smoking, we've done data here, we've got data here, or whatever, we've also done studies looking at fMRI and so on, self-criticism is the thing to go after, particularly self-criticism that comes with negative emotion, emotions of anger, rage, hostility, contempt. And when you do that, you can stimulate compassion. It's a very healing process. But for some people, the beginning to cultivate compassion, that journey into compassion, can be associated with all kinds of blocks, fears, and resistances. And then the therapeutic task is to work with those. Now, we're also, just the final point is, we're also seeing that organizations can also have blocks, fears, and resistances. And that's another story, which I hope Dr. Doty will invite me back for next year. Thank you so much.
Let me ask maybe one of you to voluntarily answer this. So we talked about healthcare organizations on the one hand, and this issue of, if you will, the problem in medicine. But what is the origin of this, do you think? Is it the nature of how we practice medicine in the United States? And I would say no, because seemingly these are types of problems all over the world. Is it that it's a financial constraint? Is it the corporatization of medicine? Or something else? Does anybody just want to make a comment?
Is that on? Oh, here we go.
Actually, could you do your thing again about the sexy little...
You want me to ask? This isn't a sexy voice. Okay, well, as you probably know, in 1945, we built a health service that became a national health service in England. And we have gradually seen a deterioration in the ethos of that service, which is almost certainly due to the business ethic that crept in with Margaret Thatcher. Now, it's not me that's saying that. There have been many, many analyses of what's happened to the NHS. We've recently had a major report called the Francis Report, which if you haven't read it, I should read it. It was based on a hospital in Staffordshire where something like 400 people died where they shouldn't have died because of the quality of care. Now the problem is that, and I think this is, again, Philip Zimbardo's work talks about this, there was nothing particularly bad about the hospital. The hospital wasn't made up of a lot of psychopaths. It was very clear that it was in the structure of the hospital trying to meet hospital targets with reduced budgets. And so I think that it's not the only thing, but the first thing is to look at the political agendas which are driving the business model of healthcare. And we need to think about whether we're happy with that, and if we're not, we need to start choosing politicians who are really going to think about how we finance healthcare. Because we're all getting older, we've stopped smoking, which is great, but we're dying later of long-term diseases. See, so we need to address the fact that medicine is getting better. We can do wonderful things. A colleague of mine works in neurorehabilitation. People who would have died 20 years ago in car accidents are now surviving. Fantastic, fantastic. But it costs money. And we all have to own up to that.
I really agree with that. I think we have a different kind of model now, that efficiency and productivity are top on the list and also saving money. And the problem is the time with the patient, the relationships, the depth of the relationships are really being jeopardized. And so people are rewarded for efficiency, for productivity. And I'll tell you a story. I'm an attending physician, and so we supervise residents and interns. And this was about 5 years ago, there was an intern who'd been there 9 months, so he wasn't a green intern, he was really experienced. I was making rounds in the morning. There was a baby there with respiratory illness, and the parents were just exhausted and dying to go home. So I said, well, they didn't want to stay another night. Let's stay in the morning. So I said, well, let's see how the baby's doing at 5. Let's see at 5 p.m. I say to the intern, why don't you call me at 5, because I'm going off to the office to see patients every 8 minutes. And so at 5 o'clock, he doesn't call. I call him, and I said, well, how's the patient doing? He said, I don't know. The computers are down. So I think we need to think about how can we work within the technology, which can be very helpful, but also how can we change our systems? And he didn't listen. He didn't listen to the patient, listen to the lung fields, and I had to say, bite my tongue and say, can you go listen and then call me back? And I want to have you do the vital signs, because I know what they are on my computer. What the nurses have put in, I want to know what you'll put in. So this is the kind of thing I could tell you story after story. We're losing clinical reasoning, common sense. We're over-protocolized. So I think if we can, there's got to be some flexibility. It's not all cookbook.
I'm sorry that I have to cut your conversation short because we could go much longer, I can tell. But I want to let you know that lunch is in the Fleet Room, as it was yesterday, and immediately following lunch, the poster session is in the Golden Gate Room, which is in a different building than this one. So we will see you back here at 3:15 for the remainder of our program. Enjoy the poster session.
Thank you.